Hello, this is Sanisha. I'm going to present my review of literature about HPV vaccination and cervical cancer. So, according to the World Health Organization, the fourth most frequent cancer among women in the United States is cervical cancer. 4,000 women died from cervical cancer in 2016, and human papillomavirus, or HPV, the most common STI in the United States, is a known causal factor for developing cervical cancer. The HPV vaccination regimen was approved first by the FDA in 2006, but in 2017, only half of adolescents had completed the vaccine series. This information causes me to think about a lot of questions, such as, is the HPV vaccine effective? Why aren't people getting the HPV vaccine? And what can we do to increase the rates of vaccination in the United States? My PICO question for this review of literature was, in females older than 9 years of age, how does administration of the HPV vaccine impact incidence of cervical cancer developed during their lifetime? So to find studies for this review of literature, I used the database PubMed. For all of the searches, studies were excluded that didn't apply to the PICO question regarding the population or the objectives of this study, and reviews of literature were excluded. Inclusion criteria were studies that were available as full text, written in English, and studies that were performed in the United States. Keywords for the initial search were women, HPV diagnosis, and cervical cancer. When I initially searched these terms, it yielded 20 results. Results were limited to those published within the last 5 years, which yielded 5 studies, and the study by Wilson et al. Was found from this search. And then my next search terms were human papillomavirus vaccination and cervical dysplasia. I limited this to the last 5 years as well, and the study by Flagg et al. Was found in this way. Human papillomavirus vaccination and healthcare access was searched next, also limited to the last 5 years, and I found the study by Monat et al. From this search. And then my last search terms were HPV vaccination, intervention, and women and randomized controlled trial. This was limited to studies from the last 10 years, and the study by Hopfer was found from this search. So for the review of literature section, the purpose of these studies were to examine HPV vaccination and cervical dysplasia prevalence, to analyze the perceived risk of getting cervical cancer and people's attitudes about the HPV vaccination, HPV vaccination in metropolitan versus non-metropolitan areas, also focusing on healthcare access and socioeconomic status, and the effectiveness of a narrative HPV vaccination intervention on a population. Flag, each of the studies for this review of literature were quantitative and took place in the United States. Men were excluded because we are specifically focusing on cervical cancer, which men can't develop, even though men are eligible to receive the vaccine. In a retrospective ecological analysis by Flagg et al., the subjects were females ages 15 to 39 who had received cervical cancer screening throughout the year. A total of 17,186,531 subjects were used in this study. In a descriptive study by Wilson et al., 81,715 students in 2 Texas universities received a recruitment email, and then following the exclusions for missing data, cervical cancer diagnosis, no sexual intercourse, or being widowed or divorced, 1,105 single Texas college women ages 26 and younger ended up participating in the study. In a randomized controlled trial by Hopfer, a random number generator selected 1,000 women ages 18 to 26 from a Pennsylvania university, and then after the exclusions for being already vaccinated for HPV or for age or gender contraindications, they ended up having 404 students responding to the survey and eligible to participate in the study. In a cross-sectional study by Monat et al., 3,573 female subjects aged 12 to 17 were involved in the study. They were excluded if the Behavioral Risk Factor Surveillance System survey from their state did not include questions about HPV. Studies differed in their methods. They approached the problem from a variety of different angles. The study by Flagg et al. Used the MarketScan Commercial Claims and Encounters database. They collected data from 2007 to 2014, stratified and categorized the data by 5-year age groups, geographical region, and type of insurance plan, and then the prevalence of cervical intraepithelial lesions among subjects over the course of the study was measured and evaluated. Monat et al. Collected data through the Behavioral Risk Factor Surveillance System, specifically using the question, a vaccine to prevent human papillomavirus is available, and has the child ever gotten the vaccine, followed by how many shots did she receive. Metropolitan status and healthcare access and socioeconomic status was also addressed. Surveys were used in the remaining studies. Wilson et al. Distributed a 76 multi-part item questionnaire in which there were open and closed-ended questions about health behaviors, barriers, facilitators of HPV vaccination, and perceptions about vaccine mandates. The individuals reported whether or not they had been told they had HPV, and they were asked to state their risk of getting HPV in the next 5 years. And they also discussed their risk of developing cervical cancer, if they felt like they were at increased risk for developing cervical cancer, and how they felt about a vaccine mandate. Hopper implemented pre- and post-intervention surveys. He, in the pre-surveys, collected background information about sexual activity, sociodemographic information, and current knowledge about HPV. And then the treatment group received a narrative video intervention from either peers, medical experts, or a combination of both, where the control group was either directed to a campus web page or they received no information at all. And then a post-intervention survey was given about their intent to receive the HPV vaccine after the intervention and compared to their intent beforehand. The findings of these studies, Flagg et al. Found that all subjects aged 20 to 24 had substantially fewer cases of low-grade squamous intraepithelial lesions in 2014 compared to the previous 2 years, which is in line with the rise of the HPV vaccine and its availability. Much of the findings were impacted by changing in availability and coverage based on age groups. The oldest age group wasn't eligible for vaccination, and those aged 30 to 34 lacked information and coverage for the vaccine, while the youngest group in this study, the results were ultimately inconclusive because they didn't have enough data. The vaccine hasn't been around long enough yet. Wilson et al. Found that among subjects diagnosed with HPV, 48.4% completed the vaccine series compared to 43% of those not diagnosed. The subjects that had been diagnosed with HPV had more knowledge and experience in HPV and were therefore more likely to understand they were at risk for cervical cancer, and they were also more likely to support a vaccine mandate. In Hopper, they found that interventions including both peers and medical experts was most effective at increasing participants' intent to be vaccinated for HPV, with twice as many participants initiating the vaccine series after the intervention involving peers and medical experts both. Socioeconomic status did influence vaccination rates, where metropolitan status did not necessarily directly impact vaccination rates. Higher socioeconomic status in metropolitan areas and lower socioeconomic status in non-metropolitan areas led to increased vaccination rates for those populations. Reliability and validity. The market scan commercial claims and encounters database and the behavioral risk factor surveillance system are known reliable instruments. Validity was reduced in the study by Flagg et al. Because due to the design, it cannot be determined with certainty that the HPV vaccination was the cause of the decline in cervical lesions. Monat et al. Disclosed that the rates of vaccination might have been impacted by funding and education differences among states, but this was addressed in regression models. Wilson et al. Used a questionnaire which was validated and previously tested by other researchers, but there was self-reported data from the questionnaire which allows for some variation in interpretation, such as how one defines safe sex. So reliability is dependent on accurate responses for this survey. And then Hopper verified reliability and validity using confirmatory factor analyses and measures from existing scales. Each study had some limitations. We are missing some areas of research. Flagg et al. Failed to provide conclusive evidence for younger age groups, which indicates a need to focus future research towards those subjects younger than 20 years of age. They did note an inflection trend in adolescence, but we just need more years of data to verify their findings. Monat et al. Studied metropolitan versus non-metropolitan areas, but the BRFSS did only incorporate the HPV module in 9 states, so more research is necessary to address the whole United States to be able to generalize findings across the wider population. African Americans were underrepresented in this study while Hispanics were overrepresented. And then Hopfer only measured vaccine initiation rather than completion, which fails to address the concern of those who may start the vaccine but not finish the series, making it less effective. It also took place in a university with majority Caucasian population, which is a limited audience. And then Wilson et al. Also addressed a limited population of college women in Texas universities. So all of this research needs to be expanded to a wider population base in order to better grasp the representation across the United States. Nurses are key for education and health promotion. The HPV vaccine is known to reduce rates of cervical cancer, and as a nurse, we are able to educate and promote the best outcomes for our patients. Nurses are trained in the therapeutic relationship and being advocates for their patients, so oftentimes it is nurses' jobs to be sure that they are encouraging the best outcomes for their patients, and they have the most interactions to be able to do this. And because of all of those areas we talked about in the critique of current literature, nursing research has an excellent opportunity to pursue this subject further themselves so that we can implement evidence-based practice more effectively. So in conclusion, the HPV vaccination does protect against cervical cancer. Women lacking knowledge or personal experience are less likely to be vaccinated. Education and finances impact vaccination rates, and something as simple as a short narrative video implemented by nurses may increase vaccination rates among some women. More research will represent a broader population on this topic, and the future of women's health just depends on the continued pursuit of research in this field. A proactive approach to continue this research and implement new strategies can be monumental in improving the future of women's health. These are my references. Thank you.